Okay, thank you for those of us that are joining our YP Speaks, the Young Professionals Chronic Disease Network. So this is our bi-weekly Google Hangout series where we share knowledge and experience on non-communicable diseases. So today we have a longtime YPer and current member of the YP-CDN Advisory Council, Shusmita. She's speaking to us all the way from Bangladesh, so thank you for allowing your day to continue with us, and I will carry on and let her take over as we go from here. So Shusmita, please go ahead. Thank you for joining us again.
Yeah. Okay, so first thing, it's almost 11:30 at my part of the world. So if I fell asleep or you fell asleep during the presentation, just nudge me or something. I don't know. How do you do that? Google
Then your
Hangout
message.
No, Desiree has my numbers. Okay, I'll start with a. I don't know. Can you see my presentation slides? Hello.
Yes, let's see. Yes, we can.
Okay, great. So this is more of a like getting the lay of the land kind of a presentation. Just wanted to highlight a little bit more about non-communicable diseases, nutrition transition, and policy in Bangladesh. We all know that Bangladesh, when we hear about Bangladesh, we think about flood, we think about natural disasters, we think about climate change and its effects, and we think about a lot of skinny women and skinny children, and a lot of people dying of diarrhea and other communicable diseases. But interestingly, we are, like many other developing countries, we are going through a epidemiological transition, and that's how we are having both the burden of communicable and non-communicable diseases among our population. And that's why I thought maybe giving you a little bit of lay of the land would be you would find it interesting. And I would talk a little bit about the policy responses, how the current policies of the country are working, and how the donor responses and government responses, issues like that. So in this presentation with non-communicable diseases, I have covered hypertension and diabetes, and the reason is because cardiovascular disease and cerebrovascular diseases are the leading cause of death among adults in Bangladesh, and hypertension and diabetes both are intermediate risk factors for developing cardiovascular and cerebrovascular diseases, and these are actually underlying cause for many later stage complications. I would also talk a little bit about the nutrition transition that the population are going through from being undernourished to overnourished, and the population that I'm going to focus are women from reproductive age. So can you guys see the second slide where I have spoken this thing? So when I change it, if you don't see it, just anyone let me know. So
we will.
Okay. So let's see how are we doing with the hypertension and diabetes, and these are all data from the national survey that we did. I was part of the team for the National Demographic and Health Survey. This survey was funded by the USAID, and this is actually this was actually a shocking result for us. To see that almost 1/3 of the women who are age 35 and over are actually hypertensive. So it's not that we got reported numbers, these are actually diagnoses. So we had people who went to households and did a national level survey, and the total number of samples were over 100,000. So it's a very large survey that we did, and we found that almost 1 in 3 women has hypertension and 1 in 5 men over the age of 35 has hypertension. And you see for diabetes, it's almost 1 in 10 for both men and women that are suffering currently from diabetes. So we wanted to see, because in Bangladesh, one of the problem that we always face is population. So it's a very small country with 160 million people living in the same country. So we wanted to see what does this 1 in 5, 1 in 3, or 1 in 10, or 10%, 15%, what does this mean? So the thing is, and how is this going to be in 2025? With this calculation that you are seeing now in millions, these are very conservative projections based on the current rate of population. But as we speak, population rate is it grows. The population grows. So this is a very conservative projections, and this would be so the in 2025 the numbers will be more than this, not less than this. So today we have 12 million people who are hypertensive, and 13 million people who are pre-hypertensive. And if we collect it together, so around 25 million people who are hypertensive or pre-hypertensive, and within the next 11 years, because we are almost done with 2014, it's going to be 39 million people. So just think about think about a country where you have 160 million population and 39 million of them has hypertension. Same goes for diabetes. You think about 160 million population living in a country, in a very small country, and in 2025, 27 million of them would be either diabetic or pre-diabetic. So the magnitude of these diseases and the burden it's really high. And one of the questions that we asked during the survey and during the evaluation, I would say, not the evaluation survey, is that we wanted to know about the awareness about their physical status. Like, does the people know that they have been living with diabetes and hypertension? What is their treatment and adherence to medication? And we found that for hypertension, their awareness level of being an hypertensive, the treatment and adherence of medication is very low. Here I'm showing you only the side of the respondents were women, and as you can see, almost half, 40%, like the red portion of the chart, they didn't even know that they had hypertension. They had no idea. So this was during the survey they got diagnosed. And among the people who already knew that they had they are aware about their diabetes status, amongst with them 45% are taking who are taking medicines does not have a controlled blood pressure. So you can see that whoever who is aware and taking medicines, among those people, 45% does not have any idea about does not have any control. So you can see that how this having medicines and not controlled blood pressure, it's very strenuous for your health, and it increases the risk for cardiovascular diseases and cerebrovascular diseases. For diabetes also, almost 60% of the women, they were not aware of their situation, and 1/3 of them who were taking medicine. Among those 60, among the people who knew, 1/3 of them only 1/3 of them were taking medicines, but 60% didn't have a controlled blood sugar. So here also the adherence level, the physical status, the treatment, and the knowledge, these are also very low for diabetes. I will now move a little bit into the nutrition transition, because I think this few slides has already given you idea about the magnitude of the problem for NCDs for women in here. So it's just see this graph, and you see these are also data from 2000, 2004, 2007, and 2011 data for the DHS. So that's the only national survey that we have that happens after every 4 years, and the method is same, so we can do trend analysis from that data. And that shows that in 2000 we had the difference between undernutrition and overnutrition, and here the black line here is actually BMI over the body mass index for over 25 or above kilogram per meter square, and the yellow one is actually BMI less than 18.5 kilogram per meter square, which accounts for, the yellow one accounts for undernutrition, and the black one accounts for overnutrition. And you see In 2000, the difference between undernutrition and overnutrition was 40 percent point. Within 4 years, this difference came down. So the women who were who were undernourished, it decreased. But at the same time, proportion of population or women living with overnutrition or becoming overnourished has increased. So the difference came down to 29%. Again, after almost 4 years, like three, because the 2007 data, 2007 survey was done late stage of 2007. So it's almost 4 years. It again came down, and the difference was only 18%. And now, when we did the 2011, the difference was 7% point. And currently, we are doing another DHS. 2015, we will be doing another DHS, and I'm quite sure that this thing is going to cross path, and we would have more people as overnourished and less people as undernourished. So my point of discussion here is that the nutrition transition that is happening in here is actually the nutrition transition that is actually happening here. Whatever nutrition interventions or initiatives or policy and dialogues and everything that is going on in here, we do not have we do not have a healthy woman population. They are either undernourished or overnourished. So that's something that we that the country is struggling with. So what is the implication in here? The implications are same as any other country. These are chronic and lifelong conditions, and the cost is huge. It's in terms of money, because for clinical management. So just to give you an idea, the cost for clinical management for only diabetes, according to the International Diabetes Federations, like the minimum cost of treating diabetes is 260 million USD, and this 262 million US dollars is actually equivalent to 24% of our whole ministry's budget, Ministry of Health's budget. So you see, if currently the number of population are diagnosed with diabetes, if the government has to provide treatment for all these people, and for the lowest amount of clinical management, the government have to allocate 24% of the total budget for the ministry's total budget. So you can see the implication of the health system is actually also very high. So we were doing, I was doing a policy response, a policy analysis, and I reviewed around 17 national policies that relates with NCDs and nutrition. Among those 17, 11 had nutrition, mainly undernutrition. So undernutrition related policy, program interventions, funding outlines, but none had NCDs. Then we found two of the policy papers, the Urban Health Policy and the NCD Strategic Plan. Both had under and overnutrition policies, but in terms of program funding and funding outline, nothing was on for overnutrition, and even for NCDs, the allocations were really very skimpy. We moved to donor responses. How? Because you know this is a donor. We still have donor dependency, and I reviewed 10 country strategy paper, and except the WHO, no one had a clear policy, program, or intervention or funding outline on overnutrition and NCDs. Two of the very big, because Asian Development Bank and Swedish SIDA, the Swedish Development Agency, they actually provide a lot of the support, like majority support for the urban health program in Bangladesh. And as you know, 1/3 of Bangladesh, more than 1/3 of Bangladesh is now urban areas. This too has nothing on NCDs or nutrition. They had some focus, but everything is on undernutrition, nothing on overnutrition, nutrition transition, or in non-communicable diseases. So before I go into the SWAP, but SWAP, it's actually a sector-wide approach program. It's a World Bank concept where all the donors and funders and bilateral organizations, they create a pool fund, and they provide pool fund in there to reduce the risk of overlapping programs and reaching the people to its maximum potential. And then what they do is, it's called the sector-wide approach, and we have been having this is the third sector-wide approach that is going on in Bangladesh. And this one is called Health, Population and Nutrition Sector Development Program. It's the HPNSDP, and it identifies, thankfully, non-communicable diseases and overnutrition, obesity, these as a challenge. And it has program outlined under the non-communicable disease and National Nutrition Services operational plan. So each of the HPNSDP or the whole sector-wide program has its own operational plan, and it has two separate operational plans. But both these operational plans have too many things on their plate. Just see, the non-communicable disease operational plan has 10 diseases in there, all their associated risk factors, treatment of all these diseases, acid violence, occupational health, workplace safety, disaster, climate change. There are like so many other things, everything clumped into non-communicable diseases. And for the National Nutrition Services, it has mentioned overnutrition or obesity, but it mainly focuses, and the funding also focuses on undernutrition, mainly stunting, wasting, chronic energy deficiency, micronutrient, nutrition information system, school gardening, and all those things. And I know this is a very depressing situation that I'm sharing with you, but there is a little hope, ray of hope. Bangladesh is one of the country that is coming out with a country strategy paper based on the global monitoring framework and global action plan, which has been developed by the WHO. Unfortunately, there is no indication of further allocation. However, the conversations has started. The ministry has given a very, I would say, able leadership to the non-communicable disease operational plan, which to some extent is very important for a country like ours to have a good leader in the right place. And let's see what happens in the next coming few years. And I think that's all. Thank you.
Thank you very much, Shusmita. So for those that did have a chance to join us a little later on, so we did welcome Shusmita from Bangladesh. She's actually in the field right now. She is a director for NCDs in Bangladesh-based NGO Eminence, so staffer there, and a nutritionist by training, so she'll have some great information to share for questions and discussion that can ensue. Would any of our participants like to chime in with comments or any points to add?
Oh, I've got one. Hi, Shusmita. My name is Chris Ronson, and I think that one of the best slides that you put up there actually was that chart that showed the narrowing of the gap between like obesity, overnutrition, and undernutrition. So as far as the weight gain, how big of a decline there's been in the malnutrition while seeing these rates of obesity go up. That was such a telling graph as far as how strong the nutrition transition is. So I'm very glad that you included that, as well as some of the numbers on how underrepresented the focus on obesity is. So you see most nutrition-based funding programs are still doing nutrition supplementation and undernutrition interventions, but no one is looking at the non-communicable diseases and the rise of obesity as countries continue to develop and further sort of get involved in this quote-unquote Western diet. I thought that was very compelling.
Thank you, Chris. It's actually, I wrote a paper on nutrition transition and the policy responses. I would actually share the policy document that came out from the National Demographic Survey and the paper from which I quoted that slide. I worked on both the papers, and I would be happy to share it with everybody who came here today and for further reading. And if there is any other questions, I would be happy to answer.
I have another, if nobody else does. I've done some nutrition transition-based work in India and Nepal, and one of the trends that we've actually seen, while there is an increase in obesity, we also do programs in Vietnam, and that's where we've seen a majority of the incidence of obesity getting higher. But as far as like we'll work in Dharavi with a number of NGOs and in other like slums in Mumbai, in both the urban and the rural areas, we're seeing some obesity, but we're also seeing like a secondary malnutrition because of the nutrition transition itself. Children are moving away from traditional diets and they're eating these nutrient devoid foods. And so they end up still having stunting, still having wasting. Even though they're getting calories, they're not getting the nutrients that they need. Are you seeing trends along those lines too, where there's like children are overeating, but they're still malnourished?
Yeah, one of the problems that we have is that our diet is, as you work in India, you know that we tend to eat a lot of carbohydrates. So we would have, and we don't have too much of food diversification in terms of fruits and vegetables intake, fresh fruits and vegetables intake. We either boil or fry our vegetables to death. So there's no nutrients, you get it, right? And we depend on potato, and so we would have a plate full of rice and potato and a little bit of lentil soup or dal, that as we call it. So it's very carb based diet in there. So that's one thing that's been a killer. Another thing that we have is the thing that's a food less consumption of fruits and vegetables. Another thing was the rise of I would say the marketing, as we call it, the marketing monster of the big food industry. Thankfully, we do not have a McDonald's now as of yet. We do not have a McDonald's in Bangladesh, but we do have Pizza Hut. We do have all those fast food shops, and yes, everybody is there. And the rise in so we were doing a little bit of analysis on the from the Export-Import Bureau, and we were seeing that for the last 5 years, how many so the sugary drinks and beverages, how much it has been a shooting increase of importing sugary beverages in here, and the consumption of Coke. So you can get like the soft soda and kind of thing. So if you also look into their sales report, of course people drinks it, that's why they sell it, right? So if you look into their sales report also, it's shooting up high. And some of the sales report, they have their sales report, it says that it's in rural areas it's going up, and the sales for soft drinks in rural areas, in urban areas also, it's very popular among the youth, because it's a very hot and humid country. You try to buy these things if you have a little bit of money in there. And we are having a improvement in our economic situations as well as we speak, thankfully. But this also increases the purchasing power for people. So I think this may be another reason. And genetically, South Asian population is predisposed to non-communicable diseases. That's what the genetical studies shows us. Okay. So consider all these issues. We are like the time bomb is bursting in some places. So
yeah. Well, and I remember reading a report that said in a 4-year period, I want to say it was 2002 to 2006, but I'd have to look back at the article, that PepsiCo like tripled their spending in Southeast Asia on like junk food marketing and promotions and things like that. And you were saying as the economic factor of Bangladesh improves, people are now buying more of these things because maybe they have a little more income or they have more access. Do you think it's like a marketing situation or an education situation or even socioeconomic?
Yeah, yeah, it's. I would say the industry is doing a better job than us. They're reaching people. I always say that the industry is doing a better job than the public health people. We reach people. We try to sell death by saying that if you drink this, you will die, you will have these diseases. That's how we try to reach the people, and people doesn't want to listen to unhappy things, right? And industry sells them happiness. You just remember the Coca-Cola advertisement. It says that if you open up a bottle of a Coke, it opens happiness. So that's what happens. For me, it's more of a like reaching more people. How do you reach more effectively? We are not doing a good job of reaching people innovatively or more effectively. That's one thing. Then the purchase power is there, and of course education is there. How many people knows that it's actually doing more harm to your body than giving you a quick solution, the fast food or the junk drinks? So that's a personal opinion.
Okay. Thank you for answering all my questions. I'm done monopolizing.
And does anyone else joining the Google Hangouts have anything they want to ask? We have enabled the question and answer box as well on our event page. So for those that are viewing the call, feel free to chime in. If you don't get your question in now, we are welcome to following up after the fact. I can put you in contact with members of our organization, our lovely speaker here as well. And we can go from there. Yeah.
Okay. I don't think we have questions.
Sorry, I was muted.
Yeah, I was going to say, I'm like, Jordan, I think
I was talking, but you can hear me. Shusmita, thanks for the really great presentation and for providing some insights into what's happening with the nutrition transition in Bangladesh. And I guess my question is, in terms of where we're, as a public health, as we're behind from industry, do you see some opportunities for regulating the industry in Bangladesh in terms of policy? What's the situation on that, regulating marketing, and what's the government's sort of stance on that? And do you also foresee opportunities to change industry maybe from the inside, approaching industry directly?
Regulation. Let's talk about that first. Regulation is it's a everybody who works in anti-tobacco control, they knows that how the industry and the people, they can lure away the policymakers and the people who makes the policies and implements and regulates, and show them a lot of money in front of them, and make sure that the strong regulation is never there. So everybody knows tobacco kills, but still tobacco regulation is not very strong in action. On paper, it's very good, but in action, it doesn't work. So I don't even in Bangladesh, I don't see. See, the problem is with the government or the donor or the people who works in public health in Bangladesh. They don't see non-communicable disease as a public health hazard. They see it's a disease. It's a clinical matter. People get a heart attack. They'll go to the hospital. They'll get a shot of streptokinase, and then they will have all the treatments. But this is a public health hazard. You have to prevent it. There are ways you can prevent. There are ways you can actually make sure that you do not get a heart attack or a cancer. Like there are ways for preventing some certain cancers as well, or hypertension or diabetes. If you have a diabetes, you can control it. You don't have to. So these are the issues. It's identifying that these are problems. That comes first, and we are still struggling with that identification. So I don't see, unfortunately, I don't see a strong regulation to stop this sugary fruits and vegetables. There has been very boutique initiatives. My organization works in there. I'm very proud of the works that we do, but considering the national response, it's almost nothing. National level response. And there are other organizations who works in there. They have their own silo of diseases. And one of the problem with this chronic non-communicable diseases is there are so many diseases in there and so many risk factors in there. So which one to do, which one not to do, even they have a higher allocation for non-communicable disease at a whole, but when it comes into the silo, it again gets divided into so many issues in there. So then it becomes hard to work. So just one example I'm going to give you. It's not about, so we have universal salt iodization, right? For iodine deficiency, all the salts that we produce in Bangladesh has been fortified with iodine. So whoever takes a salt gets the iodine in there through the salt. And the people who works on iodine, like iodine deficiency disorders, IDDs, they would encourage people to take more salt. So you know how it contradicts with the population of Bangladesh, where 1 in 3 women are hypertensive and 1 in 5 men are hypertensive, and some of the people who are talking about micronutrients are talking about taking more salt so that they can get more iodine in there. So you see the conflict of conversations among the public health workers as well. So that's does that answer your question? I know it's a very depressing situation.
But you're tackling it, right?
Oh, trying.
I think you speak to a very important point, especially with the medical approach. The buy-in from that sort of, I guess, Band-Aid application to preventative measures is sometimes missing piece in the puzzle of, or the result, which is chronic disease a lot of the times. I'll open the floor once more, but if we don't have any more questions, I'll just thank you again for joining us today in the great talk. I'm sure it spurred a lot of thoughts, hopefully, in our viewers that will be joining us later on, and especially our YP community as the video is disseminated from here on out. And if that is the last of the questions, well, I thank you, Shusmita, for joining us for, I guess, our fifth session now of or YP Speaks. It's been a great turnout, and we're so happy to have welcomed you and for your contribution. Thank you for those of us that are joining in. We will have another YP Speaks in about 2 weeks' time, so please stay tuned for specific date and details, but it will be running at 12 p.m. Eastern Standard Time from there.
Thanks, Thank you so much. Thanks, everyone.
Yeah. Bye.